I have the privilege of introducing Beth. Beth Rosen MS, RD, CDN, is a non-diet registered dietitian, as well as the owner of Goodness Gracious Living Nutrition in Southbury, Connecticut. Beth has a bachelor's degree in dietetics from the University of Maryland, a master's degree in nutrition education from Columbia University, and she's been working in the field for over 20 years. Beth has helped her clients find relief from digestive disorders such as IBS, small intestinal bacterial overgrowth, gastroparesis, and colitis, and has also been able to share her knowledge as a GI dietitian with other health professionals through channels like this very one. Beth has also designed techniques and programs to empower chronic dieters, disordered eaters, and those in recovery to mend their relationship with food and their bodies. She has written for major online and print publications like Huffington Post and FabUplus magazine, is a recurring guest on the Fox 61 morning show in Hartford, and she's created nutrition programming for individuals, professionals, and community groups. To learn more about Beth, her work, and her philosophy, go to her website at www.goodnessgraciousliving.com. And with that, I'm so excited to turn it over to Beth. So I will let you take it away, and I am going to have you take over controls and display your presentation.
Thank you so much. Let me get my slides up to share with you. And let's get this up here. There we go.
Fantastic.
Okay. And there they are. Well, they're coming. They're loading. Good evening, everybody. Tonight, we are going to be talking about the faces of FODMAPs, the uses of the low FODMAP diet and alternative solutions. As Kendall said, I'm Beth Rosen. I'm a registered dietitian. I am also a patient. So I have irritable bowel syndrome that started from post-infection from 2 bouts of C. diff. I've had 2 bouts of SIBO, so I do know what it feels like from the client side and from the practitioner side. Feel free to connect with me through my social media channels or my website. I have no disclosures to report at this time. The agenda for tonight, as we discuss the faces of FODMAPs, is a brief overview of the low FODMAP diet, as I assume most people who will join this have heard of it before if you know of Epicured. We'll also talk about the appropriate and inappropriate candidates for the low FODMAP diet, and then go over some alternative treatments for people who are inappropriate candidates. And at the end, I promise some Q&A time. So as Kendall said, drop your questions into the row at the bottom where you can click on Q&A, and we will get to those at the end. Okay, so let's start with a brief overview of the low FODMAP diet. So the low FODMAP diet, FODMAP is an acronym, stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which basically means non-digestible, slowly absorbed, short-chain carbohydrates. And these create an osmotic effect. They draw water into the gut, and they also fuel the microbes in our microbiome, and they produce gas as an effect as part of that. And one thing to note is that this diet's been around for over 10 years and was created by Dr. Gibson and his team at Monash University in Australia. And FODMAPs react this way in every body, but those with irritable bowel syndrome experience something called visceral hypersensitivity. So visceral hypersensitivity is defined as an abnormally high sensitivity level in the presence of normal stimuli, like we see in diagnoses like irritable bowel syndrome. So what Dr. Gibson explained at FNCE, which is the Food and Nutrition Conference and Expo, it's basically the Super Bowl for dietitians this October, was that FODMAPs are poorly digested by all people, but for people with IBS, when high FODMAP foods are consumed, the result is an increase in GI symptoms that includes pain, bloating, gas, and also some changes in bowel habits like diarrhea, constipation, maybe an urgency to go, and fecal incontinence. So the goal of the low FODMAP diet is to reduce the stimuli to minimize these symptoms for these people. Okay, so let's go through a brief overview of the diet itself. There are 3 phases to the diet. The first is the elimination phase, and the goal here is to remove all possible fermentable and non-absorbable short-chain carbohydrates. And this is a short-term phase, so it's 2 to 6 weeks long, and it's not intuitive, so it does need to be taught, ideally by a GI dietitian, because it's an ever-changing science and the research is ongoing. Things get updated quite often and it can be quite confusing. If the elimination phase isn't showing any change in the first 2 weeks, then I would suggest, and the diet is suggested, to stop if there's no benefit at that point and do not go on to the other phases. Phase number 2 is the reintroduction phase. And the goal here is to liberalize the diet, increase variety and choice, reduce food restriction and food fear, minimize the risk of developing maladaptive eating patterns. And we're going to talk a lot about that today. And also to help people to test back foods, systematically test these foods back when they are not in a flare or during a time of high stress or lack of sleep, by offering the foods over a couple of days with ever-growing portions with washout periods between those foods. And an unsuccessful challenge doesn't necessarily mean that food could never be added back. Maybe it gets added to the bottom of the list and tried in a few months or at another date. The final phase is the personalization phase. And the goal here is to empower our clients to know what, if any, food is a trigger for their symptoms, to help them understand when food is and is not playing a role. And this will help to minimize food fear and blaming symptoms on food. So some of the benefits of the low FODMAP diet include the ability to identify food triggers in IBS. So it also supports when food is not a trigger. A lot of times people who have IBS consistently blame food for what they're feeling until they go through the steps of the low FODMAP diet. They may realize, well, maybe stress is a bigger contributor than the food itself, or maybe it's just one food and not the multiple foods that they had removed. So that's a real benefit. It is highly effective for between 50 and 80% of people who are on it. It works well. It's also inclusive of all food groups. So it's moderately restricted for a competent eater. No specific food group is cut out, and it is well supported by research. It's not a fad diet. It's not something that diet culture created or Dr. Google created. It's actually research-based, which is nice. There are, however, some limitations. So it can be restrictive. It can be difficult to eat out or be spontaneous with food choices when you're constantly looking to see what's in it. It's also difficult to enjoy traditional American celebration foods like birthday cake and pizza. So some people feel left out during those, especially now during holiday times when there's so many great things around that people want to eat. They may contain high FODMAP ingredients. Also, it could be costly. Gluten-free items, which are not inherently low FODMAP, but many of them are good substitutes and come at a premium to their gluten-containing partners, can be expensive. And also specialty items may not be carried in all markets or all stores and have to be purchased online, and then shipping costs ensue. The diet can also be misused by those with maladaptive eating habits, but it can also be taken out of context where we know we need fiber to feed our microbiome. The low FODMAP diet can certainly be followed by having a lot of highly processed low fiber carbohydrate sources. So in that case, we're not benefiting our microbiota. So it can lead to some alterations in the microbiome. And last but not least on this list is that while it is effective for up to 50 to 80%, it's ineffective for the other 50 to 20%. So we want to take that into consideration, that there might be some other tools that could be more appropriate for people to improve their symptoms. So let's look at the people who would be appropriate and inappropriate, the candidates specifically for the low FODMAP diet before discussing the alternative options to the low FODMAP diet. So appropriate candidates include those with a diagnosis of irritable bowel syndrome. We want to make sure that when they come to us, our clients have been seen and screened by a gastroenterologist to first rule out other diseases For instance, things like celiac disease or bile acid diarrhea or pancreatic insufficiency might have some of the same symptoms, but the low FODMAP diet would not be indicated to help them. We want to make sure that the appropriate candidate is well nourished. And you can find this out through your conversation during your assessment or looking at lab work, asking if they eat a variety of foods, checking their vitamin and mineral deficiencies in their lab work. You know, plenty of times there are people that are either zinc deficient or taking too much magnesium, and both of those can lead to diarrhea, or they're poorly hydrated and they're not having enough fiber in their diet. That can lead to constipation. So we want to make sure that they have a diagnosis of IBS and not just something else going on. We also want to screen them for eating disorders to make sure that that's been ruled out, and I'll explain how to do that in a moment. So inappropriate candidates for the low FODMAP diet would include those without a diagnosis. So again, seeking care first from a gastroenterologist, ruling out celiac disease and other diseases to make sure that this dietary intervention is appropriate for what they are diagnosed with. We also want to avoid using the low FODMAP diet with people who are malnourished. As dietitians, we want to do the work to correct the malnourishment or seek the cause of it. So for instance, if somebody has a B12 deficiency that may be experiencing malnourishment, we want to fix that by either feeding them or suggesting supplementation. Children are the next group of people who would be inappropriate candidates, and that's because restrictive diets of any kind can trigger maladaptive eating patterns in children. So we want to be very careful of limiting children or putting them on any sort of diet ever. So that's important to note with children. The elderly is a group that I see in my area. We have a large population of elderly in my neighborhood where my practice is. And what I find with them is that they have a lack of access to technology. So finding those most updated food lists, using the Monash app is difficult, or they don't have a smartphone. They might have a financial strain, and because they have a fixed income, so maybe some of the foods are more expensive than what their typical shopping budget covers, and they may also be at risk for malnourishment. So we want to check these things out with everybody who comes in, but the elderly specifically. We also want to be concerned with those who are currently following a restrictive diet, specifically for maybe a comorbidity like diabetes. So we want to make sure that when we are looking at somebody who has something else where their diet's restricted for another reason, that we are not feeding them certain foods. For instance, if somebody has a histamine intolerance, many of the low FODMAP foods are actually high in histamine, so this diet wouldn't be appropriate for them. And then the last on this part of the list is those who are unwilling to make a dietary change. And you might find that people like this come into your practice where they're like, yeah, that's too hard, I don't want to do it. And then so they wouldn't be a candidate for this because it isn't something that you can do without really ramping on and doing the learning and the shopping and preparing before you start. The last one in this group of inappropriate candidates is those with eating disorders or disordered eating behaviors. And I'm going to spend some time on this group because they are common and we may not even know it. Up to 98% of people with eating disorders also have a functional GI disorder. And conversely, only 16% of people diagnosed with a functional GI disorder go on to develop an eating disorder. So in a study in 2010, the majority of the time, it was noted that the eating disorder comes first. So we need to screen for it because if the eating disorder comes first, it can exacerbate symptoms of the GI disorder. And when the eating disorder is treated, in many cases, the GI disorder goes away when it comes to people with eating disorders. But what can happen is if the eating disorder is left untreated, then the eating disorder and the GI disorder can cause each other to sort of build up. So the quote from this study was, once established, the psychological and physiological disturbances can perpetuate and strengthen each other, resulting in a functional GI disorder that can persist independently of the eating disorder that originally caused the motor and sensitivity disturbances. So in this case, what they found was if the eating disorder is not treated, then the GI disorder will not get better, and it can also then get worse and perpetuate after someone has gone through recovery. So screening tools can be a really helpful tool to help determine if someone is a competent eater or has issues with food when they come to see you. I personally, in my practice, use the ECSI 2.0 by Ellen Satter. It's a research tool to determine competent eating. The other one is the SCOFF questions, which is an acronym for the 5 questions to ask to screen for an eating disorder. And let me show those to you on this next slide. So on the left-hand side, you'll see the ECSI 2.0 has 16 questions, and there are 4 subcategories that identify eating attitudes, food acceptance, food regulation, and contextual skills when you go to score it. I put the website on there so that you can go look at it yourself, and you can see how the scoring works. A perfect score would be always, and that would be 48 points. A confident score is 32 points. I've seen as low as 4 in my practice. So you really want to screen folks for eating disorders. The screening tool on your right is the SCOFF questions. And these questions are, do you make yourself sick, like induced vomiting, because you are uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 1 stone? This was created in England, so that's about 14 pounds US in a 3-month period. Do you think you are too fat, even though others say you are too thin? And the last question is, would you say that food dominates your life? So here, the acronym is from the words sick, control, 1, fat, and food. And there are some limitations to this screening tool because it doesn't screen for all eating disorders, only anorexia and bulimia. And I'll share with you the different eating disorders and what to look out for in a moment. But I wanted to mention that dietitians do not diagnose eating disorders, but we may be the first healthcare provider a person reaches out to. So it's important to refer them to a psychologist or therapist who specializes in eating disorders for diagnosis and treatment. It's also important to refer out to an eating disorder dietitian to treat the eating disorder first. Do not treat their GI disorder with a food restriction if you suspect there's an eating disorder. So here are some common emotional and behavioral symptoms that you'll see with people with eating disorders. And you can include these questions to find out about this information in your assessment. They may share it with you anyway, but there's typically a preoccupation with weight, food, calories, and carbohydrates, and a false belief in their attitudes and thoughts about food and their bodies. There may be a refusal to eat certain foods, progressing to restriction of whole food categories. They may say that they're uncomfortable to eat in front of others. There might be chronic dieting happening or food rituals. You may also see that they have extreme concern with their body size and shape, and you can ask about these things or they may share them with you. Here are some physical signs, and you can, again, ask them about this. You may have a history that comes from a doctor and a referral, so you might know some of this. So noticeable fluctuations in weight, both up and down. They may tell you their current body weight, what their usual body weight was, what their body weight was a year ago. There might be some menstrual irregularities and difficulty concentrating. You may find that when they are sitting with you, that they're not looking at you, that they're not paying attention to your questions. It's hard for the brain to function when it's not fed. You may also notice some abnormal laboratory findings, or you may not. Not everybody has them. You may notice when you welcome them into your office and you shake their hand that their hands are cold. Of course, it's winter. We're in the middle of an ice storm where I am, so everybody's hands are cold, but feeling cold all the time is definitely a sign. You may also notice dry skin and hair or brittle nails. That's something that you might be looking out for while you are talking to your client. So again, as dietitians, we don't diagnose eating disorders, but we do play a role in recovery and the decision to recommend a higher level of care. So it's important that we know what these active eating disorders look like. So I want to run through a few of them for you. So this first one is anorexia nervosa. And that's usually what you see as a dramatic weight loss of 15% of body weight over 3 months. And you may think of someone with anorexia as being young, being white, being thin, but that's not always the case. People in larger bodies can have anorexia, a 15% loss of body weight, even in a larger body, while they're still large. may still be part of anorexia, especially if they have the other indications. And some of them are preoccupation with weight and food and calories and dieting, making comments about their bodies, the inability to maintain or resist maintaining the appropriate weight for their natural build, and also possibly maintaining an excessive exercise regimen despite weather or injury or illness. Bulimia nervosa is another one. There may be evidence of binge eating. They may tell you of this, evidence of purging behaviors. The purging behaviors may include vomiting, they include laxative use, or even exercising excessively. They may also drink excessive amounts of liquid. You may notice some physical signs of either calluses on the backs of their hands or dental issues. In both cases, in anorexia nervosa and bulimia, there's a strong tie to body image and wanting to be smaller. Okay, sorry, my slide's not advancing here. Okay. Okay, binge eating disorder is the next one. And this can happen with secret recurring episodes of binge eating, and that's defined as eating in a discrete period of time an amount of food that it's much larger than most individuals would eat under similar circumstances. And that feels like a lack of control or a lack of ability to stop eating. And there are feelings of disgust, depression, or guilt after overeating. Lots of times it's tied to low self-esteem. There's lots of bargaining that happens. They'll do differently the next day. They may steal or hoard or hide food in strange places. And they create their lifestyle so that there's times for their binge sessions. And no purging occurs with binge eating. So it's different than bulimia, because with bulimia there is purging. In binge eating disorder, there is no purging. OSFED is the next one. OSFED stands for otherwise specified feeding or eating disorder. Because OSFED encompasses a wide variety of eating disordered behaviors, any or all of the following of these symptoms might be present in someone with OSFED. So frequent episodes of binging and purging to avoid weight gain, self-esteem overly related to body image, dieting behaviors, reducing the amounts of foods or the types of foods eaten, and expressing a need to burn off calories taken in. This one is ARFID. This you might have heard of. ARFID stands for Avoidant Restrictive Food Intake Disorder. And with ARFID, we see a dramatic weight loss and a limited range of preferred foods that become narrower over time, like picky eating that progresses or worsens. And this could come from a sensory issue, or it could come from a fear of certain foods, but it gets progressively worse. There's also a fear of choking or vomiting. With ARFID, there is no body image disturbance typically, or fear of weight gain. It's different than most of the other disorders we've discussed so far, and it is increasingly more common amongst those with digestive disorders. So you may see this, or you may have seen it already. Orthorexia is also a little bit different than your typical eating disorder in that it's not so much about being small or getting thinner. It's really about being healthy, quote unquote healthy. So this group, you might see that they cut out an increasing number of food groups, or have an increased concern about the health of the specific ingredients. So they have an inability to eat anything but a narrow group of foods that are deemed healthy or pure or clean or even organic. They might spend hours fretting about what's coming up at the next place they're eating if they certainly don't have control over it. And with this, body image is not typically a concern. It may or may not be present, but typically it's about health. And with health as a measure of piousness in our society, orthorexia has increased, and many fad diets attribute to it. So think Whole30 or veganism that's not associated with ethical reasons, and even the keto diet is jumped on this bandwagon. The last one I'm going to mention is diabulimia, and this is an increased neglect of diabetes management. So you might see prescriptions being infrequently filled, or they avoid their related appointments. There might be some secrecy about managing their diabetes, or testing in front of others. There might be a fear that insulin makes them quote unquote fat. Restricting certain foods so they don't have to take insulin, or taking lower dosages. And it's typically associated with an A1C of 9 or higher on a continuous basis. And now that we know how to determine who should and should not use the low FODMAP diet, We can discuss some effective alternatives for these groups. And it's important to keep these interventions individualized. For instance, someone who's malnourished will be treated differently than someone with food fear. And in the interest of time, I'll mention a few, but there are certainly others out there currently being researched and or used. So I will start with the FODMAP Gentle. And this was written up in a recent journal article this year by Emma Halmos and Peter Gibson, and they described this bottom-up version of the diet in their article. And the aim is to remove the most common culprits from each FODMAP group instead of restricting all high FODMAP foods from each of those categories. So there was some research done before this by Bone and Associates in 2015 that indicated that behavior modifications may be as effective as a dietary intervention. And the authors wrote that specifically the participants were instructed to eat regularly 3 meals and 3 snacks a day, never too much or too little each time, never to be hungry or too full, to eat in peace and quiet and chew thoroughly, reduce intake of fatty and spicy foods, coffee, alcohol, onions, cabbage, and beans, avoid soft drinks and carbonated beverages, chewing gums and sweeteners that end in OL, and to eat fibers but distribute the intake evenly over the day. And as someone who practices a non-diet approach to health using intuitive eating and mindfulness as tools in my own practice, many of these behavior modifications can reduce stress and anxiety around food and meal times. Cognitive behavioral therapy is an effective teaching tool to teach these skills. But the FODMAP Gentle Plan took these food modifications, the portion of this that's the food modifications from this study, into consideration, but updated the limitations based on the most current information in food science and food composition. So this is what FODMAP Gentle looks like. You can see it's really not that much restriction. If you've ever seen a handout or if you've made one yourself, you have to write in really small font to get it all in to teach the low FODMAP diet. And you cannot get everything that's in the app on a 1 page. But here you'll see that in the dairy category, the only thing that's restricted is the milk and yogurt. In the grains category, it's wheat and rye, so barley is let in. In the vegetable category, what is restricted is onion, leek bulbs, cauliflower, and mushrooms. And the FODMAP Gentle diet does not include limiting garlic, but in my practice, I've included it as a food to avoid since anecdotally, it's a food that many of my clients can't tolerate during the reintroduction process. So I like to pull it out. I'm doing FODMAP Gentle a little bit more conservative. So that's what I do with that. You can do it as it's written without the garlic or with the garlic, that's up to you. In the fruit category, the fruits that are to be avoided during the elimination phase are apples, pears, watermelons, stone fruits, and dried fruits. And if you've been teaching or counseling on this diet, on the low FODMAP diet for a while, you'll note that well, in my practice at least, watermelon we call the FODMAP superfruit because it has so many FODMAPs in it. Yeah, so those are cut out. And then in the meat and alternatives, of course, we know that animal protein doesn't have carbohydrates in it, but in the alternatives, you will find that the legumes does have is high FODMAP. So we want to reduce those or remove those when we're doing the FODMAP Gentle. I have had some clients ask me if I remove the legumes. I know I could have had chickpeas. I allow the 1/4 cup of rinsed and drained chickpeas when I'm counseling on this if people ask about it. I hate to cut out anything if people are willing to add certain things in, so I will do that. So now let's look at some non-dietary evidence-based interventions that are also effective alternatives. So the first one is gut-directed hypnotherapy. And gut-directed hypnotherapy has been shown to improve quality of life and symptoms in IBS. And this therapy targets psychological coping, central nervous system processing, and the gut-brain interaction. And studies have also demonstrated effects of hypnosis on intestinal transit and the mucosal immune system. It does not have an effect on the microbiome, so that's to be noted there. In one study, there were 3 groups that were part of the intervention for a 6-week trial. There was one group that was on the low FODMAP diet, one receiving gut-directed hypnotherapy, and one receiving both interventions. And they were assessed pre and post intervention, and the data was also collected at the 6-month mark. And between the groups, there was no statistical difference between the groups when looking at GI symptoms. Both the diet and the gut-directed hypnotherapy were effective, but there was an advantage to the hypnotherapy on the psychological indices, statistically significant for reducing anxiety and depression at the 6-month mark. So this could really be a good alternative for those who can't be on the low FODMAP diet, but do have access to gut-directed hypnotherapy. So gut-directed hypnotherapy should be done by someone specifically trained in gut-directed hypnotherapy. And here are 2 directories to find those professionals. The first one is the ibshypnosis.com directory, which has not been updated in a bit, but there are still practitioners on there, so it's worth looking at. And the romegipsych.org site is a great one to look at as well. There are also 2 apps for those who might have restricted funds to spend on gut-directed hypnotherapy. One is Nerva, and the other one is Happy Inside. I have to say that I have not used these myself, but they are worth looking into to see what they're all about. The next alternative is prebiotics. And in a study by Heumann and Associates, a comparison of the low FODMAP diet was made to prebiotics. And after 4 weeks, both the prebiotics and the low FODMAP diet showed significant symptom improvement. The prebiotic effects lasted 2 weeks after the intervention ended, while the symptoms reappeared immediately after stopping the low FODMAP diet in that group. So what the researchers concluded was that after 4 weeks, both groups had statistically significant reductions in all symptom scores, except reductions in flatulence and bowel sounds in the prebiotic group. And although the decrease in the symptoms persisted for 2 weeks after, for the people who were in the prebiotic supplementation group, the authors concluded that intermittent prebiotic administration might be an alternative to dietary restrictions for patients with functional gut symptoms. So here is another one that is not diet related. So if you do have somebody in that inappropriate group of candidates, this may be another tool to use. The next one I'm going to share with you is that there is some research to show a benefit of hatha yoga as an alternative. In one study, it was noted that patients with irritable bowel syndrome might benefit from yoga and a low FODMAP diet, as both groups in the study showed a reduction in gastrointestinal symptoms. A study released this month reported that the potential mechanisms of yoga includes psychological health, self-regulation, and improvements to the stress response, as well as benefits to immune function and inflammatory processes. Unfortunately, the evidence is pretty low quality. There were only 181 participants studied total about yoga and throughout a number of studies. So this is not a panacea, and people should really listen to their bodies. There may also be some poses that cause discomfort for people with GI issues. I know I have to make accommodations for myself sometimes when doing yoga, so I would suggest that you recommend to your clients to really listen to their bodies. If something hurts, don't do it. I also want to share some over-the-counter supplements that can relieve symptoms when following the low FODMAP diet or the FODMAP gentle diet, or when using gut-directed hypnotherapy, prebiotics, or yoga to further manage symptoms. The first one is enzymes. Lactase can be used if a client has been diagnosed with lactose intolerance or notes from the reintroduction phase that they don't tolerate lactose well. And taking lactose may aid in the digestion of dairy products, allowing them to liberalize their diets, which would be wonderful. I found one study that used a dosage of 9,900 FCC units, and that study, they noted that they found a decline in symptoms and expired hydrogen via breath test. Each brand, though, contains different amounts, so the number of tablets or caplets would be determined by the amount of lactase in that product. The next enzyme is alpha-galactosidase. Sorry, I skipped on that one. You can find this in Beano. And the recent article on this, the recent study on this, said that oral alpha-galactosidase taken with high GOS foods, it provides a clinically significant reduction in symptoms to those with IBS or who are sensitive to this particular FODMAP group. So the GOS is the is the oligosaccharides or the fructans. This might be helpful in that group. And the study used 300 units to reduce symptoms and show that there was an improvement in digestion of these FODMAPs. And again, I'm not only a practitioner, I am a patient. So when I read this study, I bought some and it actually did help. So I would suggest trying it. It's certainly not harmful and it may work. The next one is peppermint oil. And there was a meta-analysis of 9 studies that evaluated 726 patients. And what they noted was peppermint oil was found to be significantly superior to the placebo for global improvement of IBS symptoms and improvement in abdominal pain. The peppermint oil group were significantly more likely to experience an adverse effect than the placebo group, but the effect was mild and short-lived, and it was most commonly heartburn. So I suggest using enteric-coated capsules before a meal, and that would reduce the risk of heartburn because those pills won't open until they get past the stomach. And that way the oil won't cause heartburn. Okay, so next ones are simethicone and iberogast. Simethicone in combination with antispasmodic drugs can have an improved impact on symptoms than just the antispasmodic drug alone. So that's just an extra help if your clients are on medications. If they are on antispasmodics, you might want to suggest simethicone, which is Gas-X. Iberogast is another one. This is a tincture of 9 different herbs, and it's known to reduce the symptoms of IBS, including bloat and gas, and does work as a prokinetic for those with constipation or who have experienced SIBO. That might be helpful too. This summer in August, there was a case study done that showed a new risk of liver damage with iberogast. So now there is a warning on their label that it's possible. This was one case that was reported. So I would just suggest letting your clients know if you are going to recommend this, that there is that risk there. Of course, there are many other supportive tools to use. But these had research, and in the interest of time, I'm going to leave you with enzymes, peppermint oil, simethicone, and iberogast. So in summary, the low FODMAP diet is effective and works for the majority of candidates, but not all candidates are candidates for the diet. So it's imperative to screen all clients, especially for eating disorders and their ability and willingness to adhere to the diet. There are alternatives to the low FODMAP diet, including FODMAP Gentle and non-diet approaches such as gut-directed hypnotherapy, prebiotics, and yoga. Other approaches exist and are continuing to be studied, so use what works best for your client. And a combination of approaches may work best for your client, so treat everybody individually. And with that, I want to say thank you and open up to questions.
Fantastic. Thanks, Beth. This is Kendall talking again. Super informative, and it looks like the rest of the audience certainly agrees. We have a number of questions that have actually come in, so excited to pose those to you.
Okay, hope I can answer them.
Awesome. So let's see, let's start with one that came in a little bit early on. Can some food items that were reintroduced and well tolerated become problematic again during perhaps periods of high stress?
I would probably say that it's not the food that's causing the intolerance at that point, but the stress that's causing the intolerance at that point. But we also know that with IBS, there is no cure and there are flares, and those flares are not within our control or within our client's control. And I say our because I'm also a patient. So noting that when someone is in a flare, they may feel comfortable going back to the elimination phase for a couple of meals. That might be a safe home base for them, especially if they're in a high stress time, if they have lack of sleep, if they're menstruating. There's a number of periods where people might feel excess symptoms arise. So my guess is that it's not the food, but the situation or the flare.
Mm-hmm. Makes sense. This was another one that came in a little earlier on. You mentioned bile acid diarrhea and how in cases of those symptoms, perhaps not using certain diets? And could you go into a little more detail about that?
I think what I was saying there was with bile acid diarrhea, we wouldn't use the low FODMAP diet to treat that. So bile acid diarrhea is really treated with a drug. And so if people get on, I think it's cholestyramine is what it's called, or there's other ones, but that's well treated with medication. So there wouldn't be a need to necessarily restrict. The only restriction might be maybe lowering the fat content in that person's diet, should they have a high fat diet, or limiting or minimizing the amount of fat in maybe a high fat meal, where our bodies might be able to tolerate a certain amount of fat, but going over that might cause the reaction. But the low FODMAP diet wouldn't be appropriate for somebody with bile acid diarrhea. I think that was the point. So I apologize if that was not clear.
Yeah, I think that was really helpful. Great. Okay, another question for you. Are there any people in the quote unquote appropriate category for the low FODMAP diet who you may decide to do the FODMAP gentle approach with first? And why might that be the case, if so?
If somebody is not so sure, like they've been diagnosed, but they're not so sure that's what it is, sometimes we'll start slow. If people feel overwhelmed by the idea of really ramping on to this, we might start slow, so we might start with the gentle. If people are appropriate candidates and I can get them on the low FODMAP diet, I feel it's easier, just do it, take the 2 weeks, let's do it. Maybe at a time like now, when it's holiday season, there's lots of food. Maybe we start with the FODMAP gentle if they feel a little better, but not completely. We might go to the full-blown low FODMAP diet, but typically I go the other way. I tend to start with the low FODMAP diet and save the gentle for the inappropriate candidates. But again, if people have body autonomy, if they say, what else do you have for me? Then I'll share it with them.
Certainly. Well, segueing into our next question, this kind of relates to that. How do you feel about FODMAP gentle being okay in the long term? Would you still do FODMAP reintroduction with this version of the diet?
That's a very good question. I would still do reintroduction. Again, I think the goal as a dietitian is to liberalize our clients' eating repertoire, to minimize food fear. And I think if we say cut out these 10 or so foods for life, that's not really giving them the opportunity to know what triggers are their triggers. If this is something that you teach quite often, as I do, I don't have one client that's the same as the next. I might have a client that only has one trigger. I might have a client that only has a trigger in one category, and then they find out they have a trigger in another category. Especially with like garlic, onion, and wheat, those are my big ones that I see. I never see somebody who has the same ones. They either have all three, or they have one or the other. So I would say introduction is still really important to liberalize the diet, but also to really individualize it to get to that personalization stage.
Right. The customization piece is so important. And gosh, these questions are flowing in so nicely to each other. The next one is another perfect segue. What would your recommendations be for the reintroduction phase? Do you have a specific FODMAP group that you typically begin reintroducing first?
So the elimination phase is very well researched, and the reintroduction phase is just now being researched. So we really go by best practices. So there is the camp of people who reintroduce specific FODMAPs in each category and start category by category. And that's fine. The way I tend to do it is I ask my clients, what foods are you missing, and what foods do you think you would successfully challenge that we took away that you want back? So sometimes it's garlic, onion, and wheat, and sometimes it's asparagus, peas, and barley soup. So it depends on the person, and I tend to go that way. If they really have no preference, I tend to start in the fructan category, just because that makes life easier for eating out.
Great. All right. Another question for you. Gosh, super engaged crowd. This is great. Do you have any studies that show flares are not in the patient's control? Just any literature around that you're aware of?
Not that I know offhand, but certainly jumping on PubMed and searching IBS and flare, you might find some research articles on that. But that's the nature of the syndrome, is that it's a functional disorder that we don't have control over. Because if you remember back, the low FODMAP diet is meant to reduce the stimuli in the gut because of the visceral hypersensitivity. So that still exists. And that's certainly not within our control. That's part of the syndrome.
Certainly. So it's certainly not a failure on their end if they have a flare-up.
Correct.
Great.
There are things that might exacerbate a flare-up, like high stress or a FODMAP sneaking into their diet, or lack of sleep, or again, menstruation for a lot of people. Or time of year, maybe allergies, maybe their immune system's low. There's plenty of things that could trigger something for somebody. And we have very little control over those things. There's ways to manage stress, of course, and to make sure we get enough sleep, but there are times when it's not necessarily within our control. And to really ensure to our patients that this is not their fault, it's part of the disease, it happens to everybody, that maybe they can have a little bit more compassion for themselves. And when they have that self-compassion, they're more likely to take care of themselves. So to find the time to rest, to find the time to reduce their stress, and find the time to prepare foods that are going to make them feel good.
Mm-hmm. Great. Another question for you, which nutrients and vitamins do you like to look at during screenings?
Well, if I can get that information, which is not always easy, working as a team, it's not always easy to get the lab work, but I will look at vitamin D, B12, zinc, magnesium. Those are the big ones. I look for, make sure that they're not anemic. But that's part of screening for an eating disorder as well. Maybe even looking at their thyroid levels. Sometimes that can throw off gut health. So there's a number there if they've been checked, right? Because you're not going to get a vitamin D reading on a CBC. That has to be done specifically, requested by the doctor to the lab.
Gotcha. Great. Thank you. And is there a standardized lab panel that you may use?
I don't tend to request specific lab work. I know there are other dietitians that have great relationships with many of their GI docs in their area. I'm lucky that I have a couple of them that will refer to me and ask me what I need from them when they do refer their clients to me. But that's not always the case. So I'll take whatever I can get and look through it. Again, my job is really the dietary intervention. So if someone comes diagnosed with irritable bowel syndrome and has been screened for an eating disorder, then most likely I'm going to treat them with a dietary intervention. And then we'll look at what's your fiber load, what those kinds of things, what kind of fruits and vegetables you're choosing, if you're choosing them at all, and really make their diet as well-rounded as possible.
Mm-hmm. Great. Here's switching gears a little bit, a question on oral allergy syndrome, and it seems to be discussed in terms of the oral cavity. Could those types of foods be culprits farther down the GI tract?
I guess it's possible. The oral allergic reaction can happen seasonally as well. So it can be related to seasonal allergies. There are some fruits that are related to some trees. And if those trees pollen is out and you eat those fruits, you may have the reaction. A lot of those are like peaches, the stone fruits do that, and they are high FODMAP fruits. Apples too, and hay fever related. So it's very possible that they are related. I don't know specifically if they're causing anything else, but it's very possible that they're related, that someone can tolerate apples in the winter, not necessarily in the spring. Mm-hmm, mm-hmm. So it's a good question.
Great. Let's see, another one here. How do you differentiate weight loss and restrictive eating relative to ARFID versus poor tolerance to FODMAPs? And in that case, how might you move forward with the elimination phase?
With ARFID, again, I'm not the one who diagnoses that. A therapist, it's diagnosed using the DSM-5. So somebody would come with that. But if I suspect it, People are typically not talking about their body weight. They may be worried that they've lost weight, and there's a concern about the weight loss, but not that they're losing the weight because they want to, or they're doing it purposefully. Usually the people I've seen with ARFID either have the couple that I can think of offhand that I've seen recently had a fear of vomiting. So eating was scary because they thought, what if I vomit if I eat this, right? So that had nothing to do with weight loss. It was a sensory thing. And then there was someone else who did vomit once from being sick and then had the fear of, it's a lot of vomiting, did have the reaction where they were afraid to eat because they might vomit. So I think with ARFID, you really want to look out to see what their major concern is. Are they concerned about the weight loss? Are they concerned about the vomiting? Are they trying to lose weight? What's their body image like? That's what I would look out for.
Mm-hmm. Great, thank you. Back to the prebiotics section of your talk. How might you go about administering prebiotics? And do you do it through food or supplementation? And what kind of dosage are you potentially looking at?
So I'm a big fan of food. So the more people can tolerate prebiotic foods, the better. Unfortunately, lots of those prebiotic foods are high FODMAP, but things like oats and bananas have prebiotic fiber in them too. So those are great uses. If I'm going to use a supplement, I'll typically use one that's marked as low FODMAP, and there's a number of them, like Regular Girl is one, Benefiber has one, that's a new one. It's called Healthy Balance. None of their other ones are, just the Healthy Balance. There's one called Great Gut. There's a bunch of them. They're certified low FODMAP. So I would go with those. I would typically have somebody start with maybe a quarter or a third of whatever the suggestion is on the package, and work their way up to the full serving. And if possible, do it in the evening. But if not, then take it at any point. That's typically when I would have them do it.
Great, thank you. Here's another question for you. Have you seen patients respond well to Creon?
I haven't seen patients taking Creon.
All right, perhaps a topic for a future, to be covered in a future webinar. Great. And we've got one more question here. I think you've touched on this a little bit, but just to kind of go over again, how do you structure the re-challenge with the low FODMAP gentle? Do you reintroduce only the few foods that were eliminated?
Yeah. So I do it the same way I would do it with the regular low FODMAP diet. I would have them choose what they want to start first and what they think they'll be successful with and what has the least amount of food fear, and then go through them. And because there's only a couple of them, I mean, there's like 10 or 11 foods, we would go through them. And in a lot of cases, I'll have clients say, well, I don't really like peaches, so I don't need to reintroduce those. And if at some point, we come back to this where they try it down the road, then they feel more secure with trying that food. But there aren't that many. I would definitely go through the low FODMAP reintroduction phase for all of those foods, if they like them. I personally don't like mushrooms. I've never retested mushrooms. I'm okay with that.
Excellent. Yes. And that kind of, sums up everything you've said about tailoring and personalizing. So that feels very appropriate. Well, we have gone through all the questions, so that's fantastic. Thank you again for being such an engaged audience and so punctual. We are right at the 60-minute mark. So I want to thank you so much, Beth, for your insights this evening and sharing all of your knowledge with us. And thanks to all of you here live for attending. Please do stay tuned for opportunities to join us again. We're really grateful here at Epicured to be bringing together such a robust and wonderful community of practitioners. And we're really excited to give you guys additional tools to help your patients feel good with food. So I would love to hear from you. You can reach me here and visit our website and check out our menu. And we really look forward to being in touch. So thank you, everybody. And thank you again, Beth.
Thank you.
Have a good evening. All right. Take care.